Our concept with this lecture is impaired perfusion and how it relates to an incompetent peripheral vascular system. I put all the YouTube videos together so that you can make sure that you see them all. Also, you can view the PowerPoint without voiceover in order to cut and paste these into your browsers. Vascular disease, or PVD, include disorders that alter the natural flow of blood through arteries and veins of the peripheral circulation. So this excludes the blood flow of the brain and the heart. PVD affects over 10 million Americans, 50 of which are asymptomatic, and it affects 1 in 3 diabetics over the age of 50. PVD can refer to problems with both veins and arteries, but when we talk specifically about arteries, it is called peripheral arterial disease, and you'll see it as PAD. If we're talking about the coronary arteries, you'll see it as CAD. Here's some more stats on PAD that are interesting. It is expected to affect over 19 million Americans by 2050. Currently, PAD affects 12 to 20% of all people over the age of 60. And then 60 to 90% of those with peripheral arterial disease are asymptomatic. Onset for about 33% of those affected begins in their teen years, and it affects 2/3 of Americans aged 20 to 30. Sometimes you'll see it said that men and women are equally affected, and others that men are more frequently affected. But African Americans and Hispanics are said to have a higher risk of PAD. What causes PAD? And the answer is clogged or diseased arteries. There are 2 terms you need to be familiar with, and they are arteriosclerosis, which refers to the normal hardening of the flexible arterial walls due to a loss of elasticity of the musculature. When young, the arteries are flexible because they contain a protein called elastin, but as age advances, there is a loss of this elastin, causing a thickening of the arterial walls. Atherosclerosis is the other term, and it is a form of arteriosclerosis that specifically refers to the deposition of fatty plaques and cholesterol globules within the arteries, causing narrowing of the lumen of the arteries, which hinders the flow of oxygen-rich blood to the organs and other parts of the body. This impairment of perfusion. Advancing age may cause arteriosclerosis, but the atherosclerosis is very much caused by hypertension, hyperlipids, smoking, diabetes, and obesity. Some people have a genetic predisposition, like there are very thin, active people who have triglycerides of 300 or more. And then stress also has an effect, as well as sedentary lifestyles, kidney disease, and being a transplant recipient. This slide shows that there is a strong correlation between insulin resistance and atherosclerosis, in that all of these causative factors are the same. They are hypertension, obesity, hyperinsulinemia, diabetes, hypertriglycerides, small dense LDLs, low HDLs, and hypercoags. The likelihood is that if your patient has one or more of these variables, they also have a degree of PAD. The pathophysiology is that atherosclerotic lesions develop. They involve both the intima and the media of the arteries. Plaques tend to localize at the bifurcations or proximal segments of large and medium-sized arteries. The vessels become obstructed, decreasing blood flow to the lower extremities. Tissue hypoxia occurs with impaired perfusion. Collateral circulation may develop, but not usually enough, and so symptoms usually develop when the vessel is occluded by about 60% or more. Looking at the anatomy of atherosclerosis, plaque is made of fatty substances, cholesterol, waste products from the cells, calcium, and fibrin. The plaque formation stimulates the cells of the artery wall to produce substances that accumulate in the inner layer. So fat builds up within these cells and around them. They form connective tissue and calcium. In this diagram, it is shown as the lipid core. The inner layer of the artery wall thickens, and the artery's diameter is thus reduced, and blood flow and oxygen delivery are decreased. A stable fibrous cap means that it is a stable thrombus. The second picture on the right shows an unstable thrombus that has cracks in the fibrous cap. This type of plaque can rupture or crack open, causing the sudden formation of a blood clot or thrombus, which, if it breaks loose, is called an embolus and can lead to a stroke, MI, or TIA. Here is a picture of a severely diseased aorta showing changes throughout all the walls of the vessel. Atherosclerosis accounts for the vast majority of PAD, even making up to about 90% of the cases. PAD obstructions usually occur in the lower extremities and are divided into either inflow or outflow blockages. Inflow impaired perfusion include vessels above the inguinal ligament, which you can see on this slide includes the aorta and iliac arteries. Outflow impaired perfusion involves the femoral, popliteal, and tibial artery. Pain is manifested differently with each type of impaired perfusion. The inflow pain is described more like a dull toothache affecting the hip, thigh, and buttocks, whereas outflow pain is described as cramping of the calves, ankles, feet, and toes. Patients can also experience both with advanced PAD. There are 4 stages of PAD, which are stage 1, asymptomatic, with a 60 to 75% of the vessels occluded before the onset of signs and symptoms. A bruit or aneurysm might be found with this physical examination at this point. Stage 2 is when there is claudication. The word means to limp. The patient will have reproducible muscle pain with exercise. Stage 3 is when the patient experiences rest pain or pain when sleeping. Pain can be relieved when they move the affected extremities to a dependent position. And stage 4 is when there is necrosis or gangrene. With chronic limb ischemia, there is a slow, gradual narrowing of the artery due to a buildup of thrombotic plaque, and signs and symptoms come on more gradually. First, intermittent claudication, which is pain from muscle ischemia, anaerobic metabolism, and buildup of lactic acid. The pain is reproducible with exercise and relieved by rest, usually within about 2 to 5 minutes. Neurological changes might include cramping, burning, pins and needles, or numbness. Our physical assessment will usually show greater impairment to one extremity. We may observe skin that is shiny and thin without hair, thickened toenails, feet may turn red when dependent and then very pale when elevated, and we need to assess for skin breakdown. Arterial sores are usually circular with a punched out appearance. And remember to use the back of the hand to feel skin temperature and the distal pads of the fingers to assess pulses. We also need to palpate and document amplitude and if the pulses are palpable or Dopplerable. Also document capillary refill time. Diagnostic tests include an MRA, which is the most widely used. It incorporates the use of an MRI with contrast to visualize blood flow through the peripheral arteries. An arteriogram or angiogram uses X-rays with contrast medium, kind of in the same way. Other tests include the segmental blood pressure readings of the thigh, calf, and ankle compared to the brachial BP. Normally, blood pressures in the thigh, calf, and ankle are higher than those of the brachial, but with PAD, they are lower. With this ankle brachial index, the ankle BP is used as a ratio with the brachial BP by dividing the ankle number by the brachial BP. The index can be found, and if it is less than 0.90 in either leg, that is diagnostic of PAD. The exercise tolerance testing gives information about claudication, and the plethysmography shows graph or tracings of arterial flow in the limbs, and when they are diminished or depressed, it shows low flow. So what interventions can be made to slow or stop the progression of atherosclerosis? And a major one is dietary changes in relation to fats. So we need to help our patients understand their lipid lab data. Like the total cholesterol is made up of LDL, HDL, and VLDL cholesterol. A desirable level of total cholesterol is thought to be less than 200 unless it is high due to high HDLs. Triglycerides, another type of fat, that level should be less than 150. The lipoproteins are substances that attach to the fats to transport them in the body. The main ones are the HDL and LDL, and we want them to be greater than 50 and less than 130 respectively. Homocysteine levels are also checked, and they are associated with inflammation, and high levels increase the vulnerability of the cell walls to form plaque. Current research is blowing the low-fat diet out of the water and saying that we need healthy fats in our diet like coconut oil, olive oil, flax oil, and good saturated fats. This slide shows you what the HDL, LDL, and VLDLs do in the body and why we need fats. The HDLs remove excess cholesterol from the cells to return to the liver. The liver then eliminates the excess cholesterol by converting it to bile salts for use in digestion. The LDLs deliver cholesterol to the cells in the body, and the VLDLs help to transport triglycerides to cells in the body. All are needed, but in the proper ratios. Some more emphasis in the future will be on having high HDLs and lower LDLs. A way to remember is that HDLs are the heavenly lipoproteins and LDLs are the lousy ones. Hypertension is another controllable variable. The higher the patient's blood pressure is, the greater chance for coronary, cerebral, renal, and peripheral vascular disease. The desired adult systolic blood pressure is less than 120 with the diastolic less than 80. Prehypertensive systolic is considered to be 120 to 139 with a diastolic of 80 to 89. Patients with diabetes should have a blood pressure that's even better, no higher than 130/90. And hypertension is now classified as a systolic blood pressure greater than 140 and or a diastolic blood pressure greater than 90. As with diet and blood pressure control, all non-invasive interventions are geared toward risk reduction and treating the underlying causes. Smoking cessation, optimizing diabetes management, and even developing a walking exercise program are all very important. If the patient experiences claudication, they may be started on a medication called Pledol. This medication both vasodilates and inhibits clotting. Other lifestyle changes include healthy nutrition, weight loss if needed, and meticulous foot and skin care. If hyperlipidemia continues in spite of dietary changes, patients may be prescribed high-dose statins. And if they have low HDLs, high triglycerides, or a high lipoprotein A, fibrate or niacin might also be added. Concerning hypertension, if hypertension continues in spite of dietary changes, the patient may be prescribed ACE inhibitors, ARBs, and diuretics in order to achieve a target blood pressure that is less than 140/90. Remembering that if a patient is diabetic or has renal insufficiency, their target blood pressure is even lower, which is 130/80. Then if hypertension continues in spite of the ACEs and ARBs, a beta blocker will then be added on top, especially if the patient has coexisting coronary artery disease. The patient may also be placed on antiplatelet therapy using aspirin, maybe 75 to 325 milligrams a day, or clopidogrel, which is also called Plavix. Other health teaching that can be done is to provide warmth to the affected extremity and prevent long periods of exposure to cold. They are to never apply heat directly, especially if they have any sensory deficits, and also drinking plenty of fluids, which will prevent increased blood viscosity and therefore impaired perfusion. An acute arterial occlusion is a medical emergency, and it is likely to be caused by an embolus, but it could be caused by a complete thrombotic occlusion. Remember that an embolus is a thrombus that has become dislodged and occludes a smaller, more distal artery. Either way, the patient presents with signs and symptoms called the 6 Ps. Number 1 is pain, which is a sharp, extreme pain distal to or below the occlusion. Number 2 is pallor, mottled pale or pale when elevated, and no edema. Number 3 is pulselessness, either diminished or absent pulses. Number 4 is paresthesia, which is decreased sensation, pressure, or numbness. Number 5 is paralysis, muscle rigidity, and cramping. And number 6 is called poikilothermic, which only means coolness to the skin. So how can an occlusion be fixed to reestablish perfusion? And there are several approaches. One is a catheter-directed thrombolysis. This is a treatment strategy for acute limb ischemia where TPA is used to break up the clot. Another approach is an endarterectomy where the vessel is surgically opened to scrape out or remove the fatty buildup of plaque and thereby increase blood flow to the extremity. Endovascular percutaneous angioplasty is the same that is done with the coronary arteries to balloon or open the closed vessel and keep them open with a stent. And an arthrectomy is using a blade or grinding device that cuts away the plaque and then sucks it out as it's grinding it up. Finally, the most invasive procedure is bypass surgery, which can be done like this figure on the slide shows you, avoiding the occluded area. The aortoiliac and aortofemoral bypass surgery is a major surgery that requires a midline incision into the abdominal cavity along with additional incisions in each groin. I have a couple of YouTubes on revascularization procedures that I want you to watch, and so you will learn a lot from those. Long-term problems, though, with PAD can lead to ischemia, ulcers, infection, gangrene, sepsis, and ultimately amputation. So now a little bit about impaired venous flow, which is also called venous insufficiency. As you know, arteries carry blood from the heart out to the body, and veins carry the blood back to the heart. Valves in the veins are to stop the blood from flowing backward, and the muscle tone propels the blood forward. Incompetent veins, however, allow blood to flow backward and pool in the venous circulation, causing edema and pain and decreased venous return to the systemic circulation. The problem is usually not life-threatening, but it is problematic and painful. Here are a couple of YouTubes that will explain it very well. Varicose veins are usually dilated blood vessels with weakening in the vessel wall. They can become swollen, twisted clusters of blue or purple veins, or superficial spider veins, which are tiny blood vessels close to the skin surface and surrounded by thin red capillaries. Clinical manifestations include lower extremity edema that worsens when standing, pain that increases when standing. There may be thin, shiny skin or thickened subcutaneous tissue. The lower leg and foot may develop a brown pigment called homocysteine staining, or it may look cyanotic. Chronic venous insufficiency is characterized by dull aching, cramping that is not consistently reproducible with activity. It can be unilateral or bilateral. There are usually no neurological changes or deficits. Pain is relieved by elevation and is worse later in the day, and pain is usually less at night. The progression of peripheral vascular disease in diabetics is compounded by such comorbidities as peripheral neuropathy and the insensitivity of the feet and lower extremities to pain and trauma. So with impaired circulation and impaired sensation, ulceration and infection are very common occurrences.